social media. We are very happy to have all of you. We are very happy to have more than 5,000 people on our YouTube channel and a lot of people on our other social medias as well. Please join us. And we have a survey about, it's a feedback survey. We are going to send you the link. So please, when you have the chance, fill that for us. So we are going to be able to know how we can do this webinars better for you and how Congenital Heart Academy can help more on your program. And we have a different way to do the poll to interact with you during this presentation. So if you are able to open on your phone or on another browser window this link, I'm going to type this on the chat box now. So we can participate on the poll, on the questions that we are going to make for you, so we can interact during this webinar. And tomorrow, we are going to have Dr. Anderson talking about morphology of the functionally univentricular hearts. And this time, he's going to talk about double inlet ventricles. And next Friday, he's going to talk about atrioventricular valvular atresia. These sessions has been amazing. I hope all of you can join and make the opportunity to ask Dr. Anderson live questions. Dr. Norman usually join us as well. So we have the best of the morphology people together to answer all your questions. And we are very, very happy to announce that Gil is doing a lecture series for us once a month. And he's sharing his amazing thoughts with us. We are very, very happy for that. The first one is going to be about TGA and arterial switch on the 29th of September. I'm going to type the links on the chat box as well. And you can find all of these links on our Facebook page and our Instagram page and on Twitter as well. And I want just to tell you about an amazing book that I've read last year. Dr. NIKAIDOH, who is our keynote speaker and is going to be introduced by Sasha in a minute, wrote this very, very sensible and beautiful book. So I really advise all of you who didn't have the chance to read it, to read it, give as a Christmas gift to your team, and even for the parents. This book is really, really amazing. It touched me very well, and all of my team here are reading because I'm sharing the book to everybody. So it's really worth reading, and you can buy it or you can get it on your Kindle, so it's available for you. I really advise you to do that. Sasha.
Thanks, Grace. I think that the people has a lot of opportunity to join next week, and all the program from Congenital Heart Academy is growing very fast. But now every worldwide meeting we do about congenital heart surgery, we have a keynote lecture. We chose Professor NIKAIDOH because of several reasons. Of course, he is a technique, the technique of Professor NIKAIDOH as moving all around the world like the music of Yo-Yo Ma. It's amazing, and I'm sure it helped a lot of children with this transposition of the great arteries ventricular septal defect. Professor NIKAIDOH was born in Japan and worked in several universities like University of Tokyo, Children's Memorial Hospital in Chicago, Children's Medical Center in Dallas, Children's Hospital in St. Francis in Tulsa, and of course at Cook Children's Medical Center in Texas. In 2011, he received a Miracle Award. So it's my real pleasure because Professor NIKAIDOH was also guest of the Congenital Heart Academy in Taormina in 2017. It's a big pleasure for me to introduce him and the lecture about the NIKAIDOH procedure. You can share your screen, Professor.
Thank you.
Like before.
Am I on the
You have the green button, share
Sure.
screen again.
I don't see my presentation.
You have to open the presentation on your computer, and then you use a share screen.
It was here.
I'm not sure this is. No, I am.
We can see your screen now. You just need to go to your presentation, but you're sharing.
Go to
No.
your presentation.
I don't really know where
Yeah,
it is.
it's
No.
down. Go to KEYNOTE. KEYNOTE is the next.
Where?
I don't.
Down you have KEYNOTE, the icon of the presentation is
You have it here.
down.
It's on the bottom on the bar right next to the Zoom camera on the right.
The next one, the next one.
This one?
There,
This.
Okay.
Okay.
All right.
I'm sorry.
all right.
This technology that really gets me. I'm sorry. Okay.
Thank you for being here, Shashi. We really appreciate it.
Okay. Well, good afternoon. Well, some people, this is good morning. And thank you for inviting me to this very, very special occasion. Thank you, Sasha, Grace, Gil, and all of that effort in making this possible. I would like to talk about aortic translocation operation, commonly called NIKAIDOH operation, as innovation. Talking about something new that I would like to always look back in the history and how we came to where we are. Venous switch operation for transposition was first successfully done at the Children's Memorial Hospital in 1956 by Tom Baffis. I worked with him a number of years there. Total venous switch operation was designed by Senning in 1959, and then later modification was published in 1964 from Toronto by Mustard. Interventricular switch was tried by Kawashima, who happens to be my friend, and Dr. Magoon in the Mayo Clinic. And later he helped me in publishing aortic translocation paper in the Journal of Cardiac Surgery. Arterial switch was tried in 1954 by Mustard, or failed. And my teacher and a friend and senior, colleague, Dr. Idris, tried in 1961, also failed. First successful operation of arterial switch was done, as all of you know, 1975 in Brazil by Dr. Jatini, and since then it has made a tremendous success to this day. One particular anatomy which defied arterial switch was combination of ventricular septal defect and a pulmonary stenosis. But curiously, this found its own repair as early as 1960s by Giancarlo Rastelli in Mayo Clinic, reported 1969. For fairness sake, Dr. Bex should be given a position in this history that he did the first translocation operation, but probably it was not a good choice, because in this particular 3-month-old girl, the pulmonary valve was resected and the subpulmonic stenosis was also resected, and they moved aortic root into that position. This patient possibly could have had arterial switch. Bix and Lecomte and others somehow did not pursue this. So I made a report in 1984, and thus today the people call this NIKAIDOH operation. But first translocation operation was done by Bix. They were probably a wrong patient, and then they didn't pursue. But anyway, the variation of translocation was reported in 2003 there by Yamagishi from Kyoto and Dr. Hu in Beijing in later time. Here's a Giancarlo Rastelli. Unfortunately, his life was cut short by lymphoma, but he believed that love wins. Unfortunately, we could meet the disappointment. In the early 1980s, and I came across a patient who had a previously Rastelli operation and developed a biventricular obstruction and a biventricular failure. Patient was considered for transposition, and while waiting for the heart to become available, he passed away. Established practice could disappoint you. When you're disappointed, be critical. Where did we go wrong? Be curious. Keep on thinking, if, what if, what if? If you keep on looking at the problem and the problem is recognized and you can find a solution, then you have new approach. Pulmonary stenosis, especially hypoplastic left ventricular outflow obstruction, does not provide adequate pulmonary valve, then you don't need it. Then you can essentially destroy it, thus cutting anterior portion of the pulmonary annulus. Then you can make a large opening to the left ventricular outlet. This came into my mind suddenly. If that is possible, then we can do direct connection from LV to aorta. So only next question to solve is how can we make connection from right ventricle to pulmonary artery? We have done that hundreds of times on tetralogy. So we can do this. So that's where the new approach was born. 2 cases were done, and they were reported in September 1984. Total number of cases that I experienced personally is 26, various hospitals, and majority of them are detransposition. And of course, there are more boys there, and the age wide range, and the sizes too. Follow-up, unfortunately, is not complete, and I have to apologize. The previous palliations are done in early cases. Many of them had systemic pulmonary artery shunts. Operation is extensive. Long cardiopulmonary bypass and long aortic cross clamp time. And in early experience, I even utilized a short circulatory arrest in 2 patients. This is probably totally unnecessary today. ECMO rescue was done in 3 patients, and the 1 patient unfortunately died from RV failure after being taken off ECMO support. This is the only death that I have. Aortic root mobilization was done in the majority of them, that they totally circumferential, and in some, leaving a left-sided coronary artery in place without mobilizing it, rotating aortic root posteriorly. If you do that, of course, right-sided coronary artery will be stretched and it needs reimplantation. VSD closure was almost always successful, and then many of them didn't even need any patch material. If you take a little bit more of right ventricular wall under the aortic valve, usually that will be quite sufficient to work as a VSD closure. I had a hard time reconstructing a right ventricular outflow tract. And it was because posterior movement of the aortic root will compress the proximal portion of pulmonary artery, either the right side or left side. If you use Recontruction maneuver, this can be avoided. So the last 6 patients had Recontruction maneuver quite successfully. Early issues are RV outflow obstruction, as I mentioned. Right coronary artery could be stretched. ECMO could be needed. But again, with a good technique and a good myocardial protection, probably this is not a necessity to this at this point. Atrial flutter fibrillation, I didn't really know why, but long aortic cross-clamping and exposure of atria to room temperature could lead to this kind of complication. One patient had bleeding from aortic suture line posteriorly, and this is one significant complication, although the patient survived well without any neurological complication. Late reoperations, left ventricular outflow tract is well maintained. RV outflow tract, I didn't protect at all. 10 patients had reoperation, and especially if they have valve the conduit, that demands reoperation over and over again. Mitral valvuloplasty was needed in a patient who had endocarditis years later. They have, so this is nothing to do with the translocation operation. And one patient who developed right atrial distension, and many years later, and then needed a Mason operation, pacemaker implantation, and pulmonary valve implant. Long-term follow-up of 20 years. They not all patients went 20 years, but some patients indeed reached 20 years. And they have this yellow straight line is my series. And unfortunately, Rastelli group continued to decline in the survival curve. These pictures are shown in the article that I recommended that has appeared in 2016 in European Journal of Cardiothoracic Surgery. They have, once you mobilize the aortic root and divide the pulmonary the artery, you can divide dysplastic small pulmonary annulus down into the infundibulous septum, into the ventricular septal defect, thus enlarging the left ventricular outlet. The remainder of the reconstruction, all of you know how to do it. And Recontruction maneuver was done, and one large patch will make connection from RV to PA. Of course, there's no pulmonary valve in these patients. Because of the pulmonary valve, idea to save the pulmonary valve, the Yamagishi came up in 2003, half-turned the truncal switch. And a similar thinking was carried out in Dr. Hu in Beijing, that he called this operation double root translocation. Sparing a pulmonary valve, it's a good idea. Bilateral coronary transfer is needed. Recontruction maneuver is utilized. This operation was expanded further into more complicated congenital heart surgery, such as double switch operations. These are reported already as early as 2005, Morel, Hu, Raska, and expanded to other types of more complicated anatomy to this day. This is Yamagishi's operation, the mobilization of double root, from the base of the heart. And Dr. Meyer in Austria has been doing this operation quite extensively. Yamagishi's group pointed out that if the pulmonary artery is small, and then probably NIKAIDOH operation is not that bad, moving aorta not too far. But if it is large, relatively large, and then this movement could jeopardize coronary artery and so forth, and there was legitimate criticism. Then issue is, how narrow is the left ventricular outflow? If left ventricular outflow tract is mild and fixable, like Dr. Beck's patient, you can do arterial switch after adequate repair of outlet of the left ventricle. You can do arterial switch. If it is moderate, yes, NIKAIDOH operation or a half truncal rotation or a double root translocation may be applicable. If it is severe, probably not all that smart to save minuscule pulmonary valve or a dysplastic pulmonary valve, and then you can consider NIKAIDOH operation. If it is totally arthritic, and then Rastelli operation or REV operation is still a serious consideration. Comparing the NIKAIDOH versus half truncal rotation, the functional pulmonary valve NIKAIDOH operation doesn't have, but truncal rotation may have. They claim that they grow. We have to wait a long-term follow-up. The coronary artery, people call it the NIKAIDOH operation is at risk, and this is protected. Protected maybe, but transferred coronary artery is not normal coronary artery. So this is debatable. And the mitral valve to pulmonary valve continuity exists. So if you try to save pulmonary valve, you could cause a problem to the mitral valve. Indeed, Yamagishi's group had to repair 3 mitral valve in the later time. Restoration of aorta connected directly to the left ventricle is important. This anatomic and physiological normalcy, we hope, will save left ventricular outflow tract in a long time. We still don't know the long-term follow-up of aortic valve on these patients. They have, so now, how you select a patient? Very carefully, checking all anatomic features involved in the patient. And so many choices are available over and above aortic translocation. You should protect the myocardium, protect coronary blood flow. Recontruction maneuver is probably needed. Avoid the bleeding postoperatively. And if you use tubular conduit, sure, you'll be back. Aortic length is sometimes a little excessive, and you may need to shorten the anterior portion of the aortic root. This is the first patient after 25 years. He had no subsequent surgery up to that point in 2008. They had 25 years with widely opened pulmonary annulus. They have probably he will need pulmonary valve implant sometime in the future. Now I work at the Cook Children's in the Fort Worth. I have had excellent and enjoyable experience with Dr. Tam, who is here, and I'm over here and as assistant. October 2016, we had a double switch operation to do in a 15-month-old sending NIKAIDOH operation. Dr. Tam's experience is also extensive, and he has, interestingly, 8 cases of double switch operations, and he is just now preparing to publish this data. I would like to end this long talk, this quote of great grandfather of modern surgery, Ambroise Paré. He was an army sergeant, served 4 kings, French kings in the 16th century. He was the inventor of ambulance, ligation of bleeding blood vessel, and treatment of wound, keeping it clean. One patient who had a severe injury survived, and people were asked, how did you do it? And his answer is here: I dressed the wound God has healed. As much as we can do so many things, we still have to depend on power from above for healing. And thank you very much.
Thank you so much, Professor NIKAIDOH. Every time I hear your talk, I learn something new. And what a legacy to have for children born with this less common form of transposition. So I'm sure the audience really appreciates what you had to share with them today. Again, I would invite the audience in the Q&A box to type in questions for any of the speakers today. It's now my pleasure to introduce Chris Knott. We've known each other for a long time. Chris trained in South Africa and is currently in the United States since 1991. He is the Chief of Pediatric Cardiothoracic Surgery at Le Bonheur, as well as full professor at the University of Tennessee, and clearly one of the absolute best cardiovascular surgical centers here in the United States. I believe we're going to talk for about 3 separate talks on Ebstein's, and Chris is going to share his extensive experience with Ebstein. And the title of his first talk today, I just was reading something on your script, Chris. I didn't realize this, is that you were honored by Pope John Paul II. That's fantastic, as well as the, of course, the American Board of Cardiology and President Nelson Mandela. So again, thank you very much being part of this esteemed panel. And now I'll turn this over to Chris, who's going to be speaking about surgical management of symptomatic neonates with Ebstein anomaly, choice of operation.
This is it, right? That's
I love how all the surgeons have a first assistant. It's fantastic to help them get this, to help them get the screens loaded.
Thanks, Gil. I just want to say a belated happy birthday to HISASHI. Turned 86 on Monday. So congratulations, and it's always a pleasure to listen to you and to be associated with you, HISASHI. So congratulations.
Thank you.
Chris, could you move just a little bit closer to your microphone, if you don't mind? Thank you.
Okay. So I'm going to talk about neonatal Ebstein's anomaly, the choice of surgical repair. I don't have any disclosures. As a background, Ebstein's anomaly in symptomatic neonates is usually fatal. 45% of those that are considered to be asymptomatic will die in infancy, usually within the first 6 months. And often they die of right heart failure, which is incorrectly attributed to gastrointestinal reflux, respiratory failure, or formula intolerance. And I've had many referrals where neonates with Ebstein's anomaly were being sent, and then the cardiologist said the patients are doing better, and we think we're going to watch them for a few months, and invariably they die 2 or 3 months later, and they die mostly with respiratory failure or gastrointestinal reflux or aspiration pneumonia or whatever, and it's, I think, mostly related to right heart failure. In the early neonatal period, the deaths are mostly due to a circular shunt, which results from a large ductus arteriosus, which is directed directly at the pulmonary valve, which is regurgitant, and then with poor ventricular function and ASD, you have a circular shunt, and those patients are critically unstable and very difficult to manage. This is just a basis for what happens to patients that are diagnosed as fetus with Ebstein's anomaly. And from the database, there are 243 of these patients, and you can see of the 243, less than 3/4 are born alive, and those that are born alive, 1/3 of them die during the neonatal period. Trying to decide who is going to survive without surgery and who's going to not survive, we used the Great Ormond Echo score, or the GOES score. This was authored by Silva and Catherine Bull from Great Ormond Street in 1994, and it really grades the Ebstein anomaly into 4 grades based on the size of the right atrium and atrialized portion of the right ventricle as a ratio of the functional right ventricle, left atrium, and left ventricle. In grade 1 and 2, the mortality is not negligible, but it's quite low. Grade 3, if the patients are acyanotic, half of them will die within the first 6 months. And if they have grade 3 or grade 4, this is universally fatal in the neonatal period. Jane, can you help me? So this is the way we measure it, just an idea. This is the right atrium. This is the atrialized portion of the right ventricle. The functional right ventricle is tiny over here. And then you've got a small left atrium and a left ventricle. And all the slides that I'm showing you are patients that I've done 2 ventricle repairs on. So which operation for the symptomatic neonate? And there are various options. There's the single ventricle palliation, which was popularized by Bornstein, the 2 ventricle repair, the biventricular repair, there's heart transplantation, the palliative aortopulmonary shunt, the right ventricular exclusion, popularized by Shunji Sano, and then there's palliative care. Everybody knows what a symptomatic neonate with Ebstein's anomaly X-ray looks like. These are patients that are repaired, and it's quite daunting when you're faced with this in a critically ill 1 or 2 day old baby. So I believe that biventricular repair is the treatment of choice for all symptomatic neonates, with the following exceptions. If you have a GOES score of 1 and 2, or the acyanotic patient with grade 3, grade 1 and 2, I think, can be treated medically quite easily and quite safely. Grade 3 acyanotic child, I would probably delay the surgery until 3 or 4 months of age, because at that point you have the option of adding a bidirectional Glenn to the repair. Patients with small left ventricles probably need to be transplanted. Those with hyperplastic pulmonary arteries, a BT shunt is probably the most logical operation. And the critical unstable neonate with a circular shunt, you have to stop the pulmonary regurgitation. You can either stop it by ligating temporally the main pulmonary artery, or you have to ligate the ductus and add a peripheral shunt to provide pulmonary blood flow. And the diminutive right ventricle, the stance operation is probably the most suitable. So what do I mean by hyperplastic left ventricle? Well, again, this is the echo of a child that I did a 2 ventricle repair on who did not survive. And you can see the right atrium is huge, the right ventricle is huge, the left atrium is diminutive, and there's a tiny left ventricle over there, which is obviously not suitable to support a systemic circulation. What do I mean by hyperplastic pulmonary arteries? Well, here you can see the aorta. The main pulmonary artery is tiny, but the branch pulmonary arteries are 2 millimeters. Again, this is a patient that did a 2 ventricle repair on who did not survive. So the technique for biventricular repair is as follows. I think you need to do an aggressive right atrioplasty, reduction atrioplasty. You need to do a tricuspid valve repair, and I believe in the neonate, basing the repair on a monoleaflet or bileaflet repair is appropriate. The modified Danielson type repair is the easiest and safest repair if the anterior leaflet is decent size. If the posterior leaflet is absent, a de Vega type repair. A complex repair with augmentation of the anterior leaflet is necessary if you've got a good posterior leaflet, but a very diminutive anterior leaflet. And if all else fails, one can replace the tricuspid valve, although this is excessively uncommon. It's important to get the right ventricular outlet tract small so that the small cardiac output stroke volume of the right ventricle isn't taken up in the infundibulum and regurgitating back into the small functional right ventricle. So keep the RV outlet tract small. Do fenestrated ASD and repair all associated cardiac defects. This is the basis for the repair. If you've got a decent anterior leaflet, and mostly when you have a good anterior leaflet, the posterior leaflet is very deficient and the septal leaflets are well displaced and inaccessible. You take a suture from the anterior posterior commissure, a pledgeted suture, bring it through the medial wall of the coronary sinus. That creates a double orifice tricuspid valve. The functional tricuspid valve is based on this anterior leaflet, and the friend of the surgeon is this anterior septal commissure, which you don't want to touch. That's the way out of the right ventricle. Once you've brought this down, you then can placate the atrialized portion of the right ventricle. Click it again. So you bring that down over there, and then this atrialized portion of the right ventricle is placated. You have a fenestrated ASD patch, and you've got not a perfect, but a functional tricuspid valve based on the anterior leaflet. This was the repair that Danielson did for decades with excellent results in the adults. I've tried all kinds of repairs in neonates, including the cone repair. I think the basic principles are that you want to try and avoid cutting into the very fragile leaflets of the tricuspid valve in the neonatal period. And then the friend of the surgeon is the severing stitch, where you take sutures through the papillary muscle, base of the papillary muscle and chordae of the anterior leaflet, and bring it down to the septum, bringing the anterior leaflet closer to the interventricular septum to allow a more competent tricuspid valve. The patient that is the hardest to operate is the one where you have a decent posterior leaflet, but a very deficient anterior leaflet. It's very difficult to reduce the annulus, which is usually 24, 25 millimeters. In that case, when your functional leaflet is the posterior leaflet. In those cases, you really have to detach the anterior leaflet and augment it with a patch of pericardium And I would suggest that if you augment it with pericardium, make the pericardial patch big enough so that it's functional. The basic principles of the tricuspid repair is keep the tricuspid valve repair simple. The more I try to be acute and do acute repairs in the tricuspid valve, the worse my outcomes were. The cone repair is best for older infants, not neonates. Avoid cutting the leaflets if at all possible. And then basic principle, either the tricuspid valve or the pulmonary valve needs to be competent. If you have a good tricuspid valve, you can do a transannular patch safely. If the tricuspid valve repair is marginal, you need to make sure you have a competent pulmonary valve to avoid creating a circular shunt. The ideal tricuspid valve annulus is reduce it to 10 to 12 millimeters in size. Remember the 7-inch stitch and low-dose epinephrine, nitric oxide, paralysis and sedation are the friend in the perioperative period. And most of all, be patient in the perioperative period. Well, what do I mean by being patient? This is exactly what I mean. This is post-op day 1. The patient's hypotensive. The oxygen saturations are 65%. The cardiologists, intensivists are screaming, take him back to the operating room, take it down, take it down. You gotta keep the intensivist, excuse me, Gil, away from the patient. That's post-op day 1. Post-op day 3, central venous pressure is a little higher. Cardiac output is still okay, but the saturations have improved. They're now 89%. We're still on 100% oxygen, but they're getting better. Post-op day 5, euro. Surgeons are euro. Saturations are now 95%, central venous pressure is down, cardiac output's good, patient looks fantastic, and everybody's happy about the repair. And this is what usually happens. You've got to be patient with the patients in the perioperative period. That's what the chest X-ray looks like afterwards. And now I'm going to share my experience, our experience, which is a 25-year experience with all the patients, 52 patients, which I think is the largest experience in the world. 20 of these we managed medically. As indicated earlier in my talk, half of them will fail within the first 6 months, will fail medical management and be repaired in the first few months of life, and all of those survived. Those that needed to be repaired during the neonatal period, there were 32 patients. 4 patients had mild tricuspid regurgitation with polyatresia, and we just did a single ventricle palliation with a BT shunt and a reduction atrioplasty, and three-quarters of them are alive. 87% of the patients that needed surgery in the neonatal period had a complete repair. If there was no anatomical polyatresia, 91% of them survived. If there was associated anatomical polyatresia, half of them died, although once we started using small RV2PA conduits, the majority of them survived. Now, I want to share just my early experience, because like Dr. NIKAIDOH shared with you, it's okay saying, well, I did a neonatal repair, but what happens to the patients 20 years down the road? That's the crux of the matter. So these are patients with 26-year follow-up. They're the first 14 patients that I operated on, 11 neonates and 3 infants. They were the usual small age and size. 4 of them had functional polyatresia, 4 had anatomical polyatresia. 3 of these patients had had prior surgeries at different institutions. 1 had a stance repair and was 4 weeks out on multiple allotropes, was transported by plane and coded 3 times in the aircraft, and took this patient to the operating room the same night and did 11 hours, spent 11 hours taking down the stance repair, septating the heart, and I'll show you pictures of this child later. One of the children that were transferred from Denver had had a repair, had complete heart block, had a pacemaker placed, epicardial pacemaker placed, then had an ASD device closure of the ASD, then had a tricuspid valve replaced, then had the tricuspid valve prosthesis fractured in the cath lab, and then when the patient was in extremis, was transferred to Oklahoma, and I repaired this patient. And one patient in San Diego had a BT shunt placed and pulmonary artery angioplasty, and we went and did went to San Diego and helped Glenn Pelletier with a complete repair on these patients. There were 2 hospital deaths, about 14%. There was no late mortality, but interestingly, 26 years later, 5 patients have had valve replacements. One in Denver had a tricuspid valve replacement 2 years down the road. This patient had a tricuspid valve replacement in Denver. Was the patient who was transferred to me, and we replaced the tricuspid valve 8 years later. And then very recently, Harold Burkett replaced the first 2 patients that I operated on, replaced the tricuspid valve 23 and 26 years after surgery. And all of the patients are functionally in class 1, very active, and lead normal lives. These are the first patients that I did complete repairs on neonatal Ebsteins. This is the first patient who survived, and I'll show you his echo 20 years later. This patient is the 26-year-old that Dr. Burkett replaced the tricuspid valve 26 years later. And this one had his valve replaced 20 years later, both within the last year. This is the echo of the first patient that I repaired 20 years after surgery, and it looks like a normal heart with very little tricuspid regurgitation. This patient was a football player, running back of his high school football team, and wants to have a career in the NFL as a football player. So in summary, I want to show you this algorithm for the management of patients, which may be helpful for those remotely looking in at this talk. If you have anatomical pulmonary atresia and you've got a diminutive right ventricle but with mild tricuspid regurg, do a BT shunt, reduction atrioplasty, and postpone the definitive surgery, which would be a bidirectional Glenn and a definitive repair until they're 3 or 4 or 5 months of age. If they've got anatomical pulmonary atresia and they've got moderate to severe tricuspid regurg with a very small functional ventricle, the stance repair is probably a good option. If they've got an adequate right ventricle, and I believe all of them, most of them have an adequate right ventricle, a biventricular repair is important. If they've got associated pulmonary atresia, adding an RVTPA conduit is an important aspect of the repair. Those with functional pulmonary atresia are usually the most critical. If they've got a tiny left ventricle like the echo I showed you, transplantation is probably the best option. If they've got a normal sized left ventricle with mild tricuspid regurg, watch them, treat them conservatively, get them off the ventilator, try and postpone them until 3 or 4 months of age, do a bidirectional Glenn, and when you do a bidirectional Glenn, your tricuspid valve repair looks very flattering. If they've got moderate to severe tricuspid regurgitation, go ahead and do the complete repair and get it out of the way. You can expect to have a good outcome. Those patients that are critically unstable with functional pulmonary atresia, circular shunt, you've got to do something right away. Early in my career, I put them on ECMO. They don't survive. You've got to take them to the operating room and you've got to take away the circular shunt. You do that either by ligating the main pulmonary artery and leaving the ductus open, or you have to ligate the ductus, which is pointed and directly at the pulmonary valve, ligate the ductus, add a peripheral shunt and a reduction atrioplasty, and postpone the definitive repair for a few weeks or a few months. And then you can either do a stance repair or a biventricular repair. So the little girl that had the stance repair that was transported by plane from Oxnard to me, coded 3 times in the aircraft and had the stance repair taken down and a biventricular repair done. This is her graduating from school. She's now 20 years old and she leads a normal life. So in conclusion, the surgical techniques and the medical management strategies continue to evolve. Ebstein anomaly with polyatresia continues to be the Achilles heel. A small RVTPA conduit is important. Biventricular repair is usually feasible with good survival, either as a primary or as a stage repair, and the advantages of a biventricular physiology can be anticipated over time. Thank you very much for the opportunity to present this work. And this is the hospital that I work at.
Thank you, Professor Knott Craig. I don't know if the University of Tennessee will accept your patient as a football player, but I think that would be a fantastic full circle. And I love the fact that that both of our first two speakers have shown wonderful photos, because this is really the outcome, you know. And I think I heard Dr. Kirkland say this, I may be misquoting, but he said, we have to show actuarial survival, but we also have to show actual survival. And I really, really like that, that way of looking at what we all do. I was also struck when I looked at the gallery view of the incredible collection of surgical rock stars on this webinar. This is really such a treat to be able to be part of. We're going to take a short break. I'm just going to share my screen very quickly, assuming I can get my presentation up here. Give me just 1 second, please. Is my screen sharing at all, Sasha?
No, not at the moment.
Okay, I will work on that.
Yes, the only thing is that you take your time. Professor NIKAIDOH, Professor Adzenkamp, in a question and answer, is told you that you are a real inspiration for him. And they did more than 20 NIKAIDOH operation, and they are without no coronaries detached, no aorta transected. And follow-up is more than 20 years. So this is Professor Adzenkamp from Europe. Gil.
It's fantastic that we can, who would have thought when you started this procedure and reported this in the mid-80s, that we would be simultaneously sharing it worldwide to about 60 or 65 countries. I wanted to just give everyone a quick update on the World Congress of Pediatric Cardiology and Cardiac Surgery. Myself and Jeff Jacobs are the co-chairs of this. And before I give you that update, I would ask you all, this has already been pointed out, but while we're taking just a couple minutes to talk about the World Congress, if you please could open your phone or another browser or a device for what we have found to be really a fun poll and a way that we can improve the Congenital Heart Academy. And by that, type in this URL, ahaslides.com and /CHA, which stands for Congenital Heart Academy, CHA Surgery. And you'll be able to participate in some fun stuff as we take a quick break. I'm going to do this very quickly because we're a few minutes behind. The World Congress, we've been supported by over, I think over 60 partners now to get this up and running. And also have multiple societal partners, of which 19 have canceled their 2021 meetings. Unfortunately, this happened. And we had to make some very difficult and tough decisions. And we have recently decided to postpone the World Congress of Pediatric Cardiology and Cardiac Surgery to August 27th, if you'd like to write the dates down, August 27th to September 1st. So a little bit less than 2 years from now in 2023, again in Washington. And I bring this up because I'm really pleased to say that, you know, we had a really phenomenal program planned, some of which will not be relevant in 2023. And over the next 2 years, the World Congress scientific content will be presented on this forum through the Congenital Heart Academy. One of the original goals of the Congenital Heart Academy was as a proof of concept and to learn how we might be able to share educational content for the World Congress, not knowing it was going to be postponed. And the CHA has gone beyond our wildest expectations in terms of success. We've had some webinars with 2,300 people, with people from all over the world joining us. I do want to get into the poll at this point, which is really a lot of fun, assuming I can find that link. Okay, give me one more second, please. I apologize. So again, if you could log on to ahaslides.com/CHA surgery. We have 300 and something or 400 and something participants. Unfortunately, only about 60 of you have logged on, and it really would be very helpful if you could participate in the poll. So I'll start. The first question is a test question, just so that you can learn how to do this. I put one of these answers in here specifically for Dr. Dearani, and that is for you to identify, you can do this on your phone or do this on your computer, which is a bird. Who can identify which is a bird? And as you could see, most people, and I know it's an international webinar, got number 1 and number 6 correct. Number 3 is the American basketball player Larry Bird. And of course, number 5 is Bird. That's Charlie Parker, the king of bebop. Again, another test question while you log on to ahaslides.com/CHA surgery. This would be just a practice so that you can use your phone and that you could use your other browser or your iPad or whatever else device you have. I always love this question. We get quite a bit of people, number one, learning how to do this. I can't believe there are 3 people who do not like pizza, but there you go. And 7 people would put pineapple on a pizza, which I never sort of personally understood. And my favorite, for those of you who even care, is anchovy. I'll wait just a second while everybody logs on. Again, that's great. We're getting about 1/3 of the audience is currently now logged on. So I think we're going to have some very meaningful results as we get into the science. How do you hear about us? If you're on your phone, you need to advance the slide at the top that says next slide. And if you're on your desktop, this should be showing right now. We are really working on our social media platform. Thanks to Sasha and others, and Grace in particular, who's really the boss of this whole thing. She's definitely Sasha and my boss. Has been working on you agree, right, Sasha? Has been working on the webpage, which should be up and running, I'm hoping, right at the beginning of October. We're still using 1990s technology for most of us, which is email. But there's a lot of people using WhatsApp groups. And also 20 of us who've gotten emails from the Pediatric Cardiac Intensive Care Society. Where are you from? We've had people here from Sri Lanka and Sudan and Uzbekistan. And it's wonderful for me to see the people that log on that traditionally would have real difficulty getting to meetings, international meetings, either due to visa issues or financial considerations or a variety of reasons. And it's been really terrific to see that. And we have people across, I don't know who's from Antarctica, maybe they just hit the wrong button, but we have people from every continent and every time zone, pretty much, it looks like. And again, a real widespread. So again, to Chris and Hisashi and all the rest of the speakers, you're able to give your information to so many people, and we really appreciate your time. You don't have to say this, Dr. Dearani, but what is your, or anyone, but what is your age bracket? This is pretty typical for all of our prior webinars. People in general from, it's a curve that's skewed to the right, but usually, again, 2/3 of our attendees are between about 30 and 50 and at the, what I would consider early part of our careers. Gender, just very quickly. It's interesting that the distribution for surgical and interventional cath of our attendees is predominantly male. And the distribution is predominantly female for just about every webinar that we've done. Not a judgment, just a statement. What best describes your daily practice? It's wonderful to get all these surgeons on the webinar. It's just fantastic. Also, I would encourage you, if you are interested in these webinars, to share them with your nursing staffs, as well as your OR staff, et cetera. I think we have an opportunity to really educate all professions with these types of procedures. So we would certainly appreciate it when you get an email invitation to share it throughout your cardiac center. And this, just like our other surgical webinar, is the only one where the preponderance are surgeons, which, given your all schedule, is a real tribute to your interest in attending and learning from the rock stars. Which surgical procedure is ideal for TGA with ventricular septal defect and left ventricular outflow tract obstruction or pulmonary stenosis? And Hisashi, it seems there are a lot of fans out there.
Yes.
It's nice to see.
Yes.
I suspect Dr. Hasenkamp is in the yellow bar there somewhere.
Yes, he must be there.
I don't even know what a half-turn truncal switch is, so maybe somebody could type that in the Q&A box, because I'd certainly like to learn about that. All right, where nearly everybody is there. So regarding the NIKAIDOH procedure, this is the operation of choice at my institution for transposition VSDPS. Today's presentation will change the practice at my institution, is one of the many options at my institution, and is not performed at my institution. So we've got representation across all of this, all of these options, again, showing the reach and the depth of the Congenital Heart Academy. Moving quickly, approximately how many operations for Ebstein anomaly in my institution for the neonate specifically, so yearly times 5. And I'm curious what our 3 speakers about Ebstein anomaly think about this kind of volume. But it's looking like most institutions see 1 a year or less, which is certainly the experience in the places I've worked at in Philadelphia and most recently Washington, D.C. It's still a rare anomaly, and probably, I'm going to get myself in trouble here, but probably should be concentrated in just a few centers. That's neonatal Ebsteins. How about in the infant through adolescent? How many operations for Ebstein anomaly in my institution for children? So more common, somewhere between, well, a few more. Let's see what a few, we have about 80, 90 people answering just now. Again, it's in the range of about 1 per year, but certainly skewed more a bit to the right than we saw before. And keep answering or advance to the next slide. And what about for adults with Ebstein anomaly at the institution you are at? And we're going to hear a lot of this, I suspect, from the Mayo Clinic experience coming up in a couple of lectures. Joe, I don't know if your audio is on, but what's the volume at your institution now per year for young adults?
We do about 35 to 50 Ebstein operations a year, and it's about half children and half adults.
My goodness. We're going to have to start calling it the Mayo Ebstein Clinic. All right, and then the last one about Ebstein, and I appreciated this question because it's one that doesn't get answered or asked that often, which is, it's a terrible disease, the neonate with severe Ebstein. How many of the neonates die without surgery in the last 5 years, if you were to think about your recent? So certainly the majority are either all or most of them. Certainly an opportunity for, again, as I was talking about before, maybe regionalization in the rich resourced countries and see what we can do in other low and middle income countries. This was one of the questions that Dr. Knott Craig asked us to ask. How often can successful primary or staged biventricular repair of severely symptomatic neonates with Ebstein's be achieved? I decided to switch it up to a pie graph so that you guys don't get bored with the bar graphs. Chris, comments on this distribution? I don't know if he's still here. I can't see my my video.
Yeah, hey, Gil. Yes, well, I think that's what one can expect because most surgeons very rarely deal with the neonatal Ebstein. I mean, it's most of the time the neonates are now diagnosed in utero, and then we have a lot of patients that come, pregnant women that come here and get delivered and taken care of. So I think my own feeling is that most of the neonates that survive the first 24 hours after birth can be repaired at some point, either as a staged or as a primary repair.
Clearly, there's a large percentage with high drops, and in certain countries, which is terrible, and then in certain countries where termination of pregnancy is an option, it's a choice taken by many. Okay, regarding the cone procedure, this is the operation of choice at my institution for Ebstein anomaly. This obviously is for older patients. Today's presentation will change the practice at my institution. No pressure to the next two speakers. Is one of many options at my institution for Ebstein anomaly and is not performed at my institution. So this is a preface to Dr. Dearani's talk. And again, a wide, there's already 5 very optimistic, Dr. Dearani, that your presentation today will change practice. And I'm quite certain that that's true. Okay, moving to the next one. Regarding the cone procedure for older children, adolescents, and young adults, check all that apply. A bidirectional Glenn should be performed in the majority of them. Early extubation is preferred. Should include a preoperative EP study to decide on catheter ablation. It is not performed at my institution. And should include a preoperative EP study to help decide on intraoperative antiarrhythmic surgery. Joe, a few comments?
Well, I think that clearly if there's a concern or about potential arrhythmias either by ECG or by history, either a Holter monitor or placement of a loop recorder or an EP study it needs to be done. I think we went through a phase where a lot of people were getting EP studies, but I think, now after the fact, we've learned a lot. And I think that we don't do it in everybody, but we do it liberally. But I think it does require an electrophysiologist to weigh in because sometimes when you think it's needed, it's not. And other times when you think you don't need it, you probably should. But if there's concern about ablation, you really want to do that before any surgery because at least particularly with the cone procedure, you could potentially cover areas that would need to be ablated. So for sure, it should be done before surgery if there's any concern about the need for radiofrequency ablation.
Thanks. I'm sure you'll cover some of the others in your talk. Which of the following is the most difficult to represent for surgical simulation using current imaging and 3D printing technologies? People are weighing in now. All of these pictures were taken from the internet without anybody's permission. In full disclosure.
No option, no chance.
All right, we're going to hear about that toward the end of the webinar, which also suggests that the arterial switch is terrific for current imaging and 3D printing technologies. And biventricular repair is the most difficult as well as cone. So hopefully we're going to hear that as well. And then just some fun things really quickly. Type in 2 words that describe why you take care of critically ill children with heart disease. It looks like the first 2 were who takes care of those patients, but why? Why do you do your job? What inspires you every single day. This is our first what's called a word cloud. You should be able to see this if you advance your phone and type in a few words. As these word clouds move along, it's very interesting to see the words that sort of stick, like challenge and challenging and passion and rewarding. I always love to see how these develop. And certainly based, say again? Certainly based on Dr. NIKAIDOH's presentation, you got to have passion. This is particularly fun to do. And you can keep.
I'm going to say that it's very interesting because it doesn't matter.
I think Grace's mic is on. Please, this will help us a lot. I don't know what all those initials are, but this is please choose 3 topics for future lectures or webinars. If you could log on to the next slide, and there will be one more after this one, and then Grace will continue with our next speaker. So if you have ideas for topics, please type them in here. I know TGA is going to be coming up, plus on our website. TGA is the most viewed video, our TGA series. Our first one has, boy, the last time I checked, I think it was over 6,000 views. Over 7,000 views for the TGA series, so you can look at that one. DORV, they say that if you understand DORV, you know all of heart disease. Tausig Bing was popped up there as well with a form of double outlet right ventricle. And the fact that there's many small numbers mean there are a lot of different topics that people want to talk to. I'm sure Norm will be happy that it says more Silverman series on there. And we have Fontana's in there, and we have something that's going to be planned, Sasha, with Pachta. Is that right, on Fontana?
Yes. We are planning. Most of the things are planning. We are, as I told you, interested in pulmonary hypertension because you see it's moving fast. And for sure, at DORV, we have a fantastic lecture from Meryl Cohen about imaging and anatomy. So there is a lot of work, Gil. This is the problem.
Yes. It looks like we're busy till 2023. And then this is the last question. This came up in our last session sponsored by the Pediatric Cardiac Intensive Care Society, which we're talking about systems that you can use to improve outcomes at zero cost. And one of the very convincing ones presented by the Great Ormond, chaos comes up, from the Great Ormond Street group is based on the Formula One experience of having a script, of having a silent and then scripted handoff, which has been shown to not only be quicker, but to improve information transfer. And I hope to share this with the Pediatric Cardiac Intensive Care Society, where at our last webinar, we had about 10% surgeons, and this time we have a very large consensus or very large participation from surgeons. Somehow chaos is staying there. So here's a good opportunity for improvement that maybe we can talk about at our next cardiac surgical webinar. I'll give everyone 10 seconds, but Grace, if you'd like to start the next process, and then I will stop sharing.
Okay, what I was going to say, Gil, is that it doesn't matter which audience we have on our webinars, passion and challenge is always there when we ask people why they do what they do. So, and this is very reassuring for us. It's something that is very nice. Okay, so our next speaker is going to be Luciana da Fonseca da Silva. I know Luciana for at least 10 years. We worked together at Beneficência Portuguesa de São Paulo, where she helped Dr. José Pedro to develop the cone surgery for Ebstein's, and she has a very big experience on that, or doing herself the surgery or helping Dr. José Pedro. And nowadays she left Brazil. She is in Pittsburgh, where she's associate professor and attending on the congenital cardiac surgery. And she's going to talk to us today about neonatal Ebstein, the management strategies when the patients are severely ill. Thank you very much, Luciana, for being with us.
Thank you all for the invitation to participate in this important webinar. I will talk about our current approach to neonatal Ebstein here at the Children's Hospital of Pittsburgh, PMC. We know that Ebstein's anomaly is not only a disease that involves the tricuspid valve, but also the right ventricle, the right atrium, and in neonates, we can have functional or true pulmonary atresia. The pulmonary arteries can be small, the lungs can be hypoplastic due to the compression about the cardiomegaly in the fetal life. And even the left ventricle can be involved due to compression by the right ventricle. From the embryological aspect, the concept is a failure of the lamination of the inferior and septal leaflets, but also the anterior leaflets present variable degrees of tethering to the RV wall, and this makes the rotation of the tricuspid annulus in various degrees. As we can see here, a severely displaced Ebstein valve rotates to the RVOT, and this makes difficult the surgery repair, and also cause a great variability of clinical presentation and time of diagnosis. Usually when we see in fetal life, there is a normal fetal scan that brings the kid to the diagnosis of Ebstein, usually polyhydramnios. In the neonatal life, the most common presentation is cyanosis or heart failure, or even an incidental murmur or arrhythmia, related mostly to the RVOT obstruction. And in this paper by Selemacher, we can see that the early death is due to heart failure, and also the lung hypoplasia is a contributing factor. And he calls attention to those who survive the first month of life. They are still on risk of sudden death due to left ventricular dysfunction or cardiac arrhythmia. So we need to be careful in the management of those babies. In this important paper from Dr. Silverman and Dr. Robertson, it's an old one in 1989, he called attention for the risk of mortality under the age of 3 months in patients with tethered distal attachment of anterior superior leaflets. As I told before, this brings the tricuspid valve to the RVOT, and also other factors. And he described very well the relationship between the right atrialized ventricle and the right atrium area. If bigger than functional right ventricle plus left atrium and left ventricle areas would be a risk factor for deaths in those cohort. If we have a diagnosis in fetal life, then the prognosis is worse. As we can see here in this multi-center study, while the neonatal survival was only 67% in the live-born patients when the diagnosis was made in a gestational age of 27 weeks. And the higher risk babies were those with no integrated pulmonary flow and depressed left ventricle function. The pulmonary regurgitation by itself, causing a circular shunt physiology, is a strong hemodynamic indicator for risk of death. So those fetus needs more innovative approach, surgical and medically thinking. And this involves the use of non-steroidal anti-inflammatory drugs in the fetal life in those who present physiological circular shunt. And this aims to prevent brain injury due to hyperperfusion of the brain. So the future directions is to treat achieve early ductal closure, and innovative surgical management can improve the survival in this group of very ill babies. The surgical treatment is still a challenging procedure in the neonatal age, as we can see here in this paper published by the Society of Thoracic Surgery, and with data from 2010 to 2016 in 19 centers. So in this paper, the mortality was 27.4%, that's really high. And those who are in critical situation in ECMO was still higher. So we need to look for operations that can bring the rate of mortality to a lower degree. And the Starnes procedure created by Dr. Starnes in 1991 is one of those operations. And in the Starnes, we close the tricuspid valve with a fenestrated patch, and we install a BT shunt to promote the pulmonary flow, and we leave the ASD open. And this technique is important because the RV exclusion decompressed the left ventricle and is effective as an early palliative treatment of neonates in heart failure. It's appropriate for any anatomical type of Ebstein anomaly, and even surgeons that are not familiar with Ebstein anomaly would be able to do this. And the midterm survival in his experience was 81% at 10 years, but following the single ventricle pathway. The cone technique, developed by Dr. José Pedro da Silva in 1993, is a widely used technique to repair Ebstein anomaly in children and adults. In this technique, we detach the leaflets of the valve and we construct a conic structure, and we reimplant this in the tricuspid annulus. So the principle of this technique is to mobilize all the leaflet tissues from the RV wall to bring it together, suturing it in a cone shape formation. And then we suture this, the base of the cone to the tricuspid annulus, and then to the reduced tricuspid annulus, and then we have a good result. But can we apply this technique for neonatal patients like this one here? Yes, we can. If we have a good right ventricular function and good tricuspid leaflets, and if you have experience with the cone procedure, we can achieve a good result, as we can see here in the long-term follow-up at 6 and 36 months of age. But this technique, we need to think, is a complex procedure. And as we can see here in a small patient, we need to detach all the leaflets. Those leaflets are very fragile tissue, so it's a little bit complex. And then if you don't have experience with the cone repair in older children, we should not apply it to the newborn. The cone procedure promotes the reverse remodeling of the heart, as we can see here in the sequence of angiograms, and with decreasing of the cardiothoracic index in the immediately post-operative period. But who should we operate? Of course, not everybody. If a newborn comes to your CICU, you need to evaluate. If the baby is clinically stable, you should avoid interventions. You need to manage the pulmonary vascular resistance, and you need to think about the risks of AV valve surgery in neonates. But if the patient is unstable, you need to proceed with intubation, ventilation, the prostaglandin use if it's a PDA dependent situation, and also to reduction of the pulmonary vascular resistance. Also, nitric oxide can be used, inotropic support with Murinon or even epinephrine, and rhythm control is very important. And in some situations, the kid is so sick that we need to put on ECMO, like we can see in this chest X-ray. in a baby that we need to put on ECMO in the first night of life. After, we need to evaluate the adequacy of the forward flow by the echo. If we have adequate forward flow, we don't need prostaglandins. We need to do clinical follow-up. And then if we don't have heart failure signs and the kid is gain weight, we can follow with the clinical treatment and postpone the con for later in life. But if the kid presents heart failure or significant tricuspid valve regurgitation, we need to think in the PDA closure if the PDA is still open, or con in the selective neonatal case, like I said before, or even Starnes procedure, especially if we don't have experience with the con, or if you don't have enough tricuspid leaflet tissues, or even if the right ventricle function is not good. In other situations, if you have inadequate forward flow, you need to think about pulmonary atresia. It's possible that it's functional if we have like a normal pulmonary valve annulus. So in this situation, we should try to wean the prostaglandin and follow. If the patients present with no cyanosis after the PDA is closed, then we can follow the track of the clinical follow-up. But if the kid presents cyanosis, then we need to evaluate the level of the tricuspid regurgitation, if it's mild, and the cardiothoracic index, if it's decreasing, then we can follow with a BTT shunt or a PDA stent to allow the flow to the pulmonary arteries. However, if we have severe tricuspid regurgitation and the cardiothoracic ratio is higher than 0.8, then we advocate the Starnes procedure in those babies. Of course, if we have an anatomical pulmonary atresia, we need to keep prostaglandins. And then we need to follow with some intervention, following the same pathway as I said before. This is an example of a baby that was born with a very displaced tricuspid valve. We can see the pulmonary annulus is good. However, the tricuspid valve is rotated to the RVOT. And we can see the PDA is open and the valve is here. We can see severe tethering of the anterior leaflet to the free wall of the ventricle and the degree of regurgitation of the tricuspid valve here. This kid was operated in another center. It was a type D newborn, and he presented with cyanosis, and they did a BT shunt. And then later in life, he came to us, and we did a con repair with a very good result. But what we saw during the operation was a very muscularized right ventricle, and the leaflets of the valve was just here that we can see. All the anterior leaflet was really muscularized, but we were still able to mobilize everything and use it as a con. And at the end, we had a very good result with no obstruction of the LVOT and a good tricuspid valve flow. So we are able to do after the BT shunt and after the star shunts. Could we also do the con procedure? The answer now is yes. Having in mind that the right ventricle undergoes progressive involution after the Starnes procedure, we decided to do a biventricular repair after the Starnes, and we published this paper in the beginning of 2020 with 2 patients with neonatal Ebstein and pulmonary atresia, and the result was really good. Here we can see during the operation, we removed the patch used in the Starnes procedure, and underneath the patch, we can see the anterior leaflet of the tricuspid valve. And with this tissue, we constructed a cone. And also the pulmonary valve, we did a valvuloplasty, doing a commissurotomy of the valve and enlarging the anterior leaflet with a patch of PTFE. This is the pre-op exam of the baby with neonatal Ebstein anomaly with pulmonary atresia, and this is after Starnes, and this is after the cone with a good inflow in the tricuspid valve in a good forward flow in the pulmonary valve. This is another example of Starnes after the operation, a good forward flow in the pulmonary valve. And here we can see the tricuspid valve leaflet to leaflet coaptation and a good inflow and almost no regurgitation in this baby with previous pulmonary atresia. So now our approach now is to do the cone and pulmonary valvuloplasty even after the Starnes procedure. And some patients doing a bidirectional gland as an intermediate procedure, so activating the 1.5 repair. In sick kids with circular shunt, the kid can be so sick, then we need to do an immediately PDA closure in the OR. But we need to be prepared. If the kid doesn't have a good evolution, then we need to be prepared to do a Starnes procedure and a pulmonary artery closure. In this case, to allow the recovery of the pulmonary valve in the future, we are using a PTFE patch to cover the valve. And then after some time, we can do the cone and the pulmonary valvuloplasty. The Fontan operation and heart transplant, in our experience now, we advocate as a last resource. So our experience, Jose Pedro and I, we did 265 patients since 1993 to January 2019. In our experience in São Paulo. At this point, we had 19 patients here at Children's Hospital and the overall mortality of 2.4%. It is englobed the first initial experience. At this point, we had 12 neonatal repairs with 16% of mortality, and those happened in São Paulo before the ECMO program. Neonatal Starnes, at that point, we have done 2 cases, and tricuspid valve replacement, in our experience, we did only in 2 patients in all the Ebstein anomalies we have treated surgically. Our experience now at the Children's Hospital of Pittsburgh since 2016, when Jose Pedro moved to here, and I started working here last year. We have now 29 procedures, 3 after Glenn, and 3 after BT shunt. Those patients were operated in other institutions as a newborn, and then they came here to do the cone procedure. Neonatal cone repair we did in 2 patients. 1 was in ECMO preoperatively. Neonatal Starnes we have done in 4 patients, and 2 were in ECMO preoperatively. 1 had a circular shunt, and then pulmonary artery ligation was done. Cone after Starnes we have done in 3 of those 4 at the mean age of 5 to 17 months. 2 previously had a bidirectional gland, and 1 of them we did a biventricular repair. In our mortality now is until this moment 0. So in summary, the treatment must be individualized according to the clinical and anatomical presentation. The Da Silva cone procedure is a viable and durable option applicable for all anatomical types of Ebstein anomaly in our experience, and can be used in neonatal patients as a primary biventricular repair in specific situations after BT shunt and PDA stent, as I have shown, and after an initial neonatal restart procedure. For critical newborns with Ebstein anomaly, the staged approach with STARS procedure followed by CON is favored over primary to biventricular repair in the very sick babies, in our experience. Thank you so much.
Thank you, Luciana. That's an amazing experience, and we are very happy to update our knowledge about this disease that is a real drama for most of the cardiac center of the world. We move now and we go to probably, as Gil said, one of the most experienced, probably the biggest experience in Ebstein anomaly. And we have here the director of the Department of Cardiovascular Surgery at Mayo Clinic, and he's also professor of surgery. And at the same time, he's a simple president of American Society Society of Thoracic Surgery. So it's a big pleasure to have Professor Dearani about this experience with the COM procedure. Thanks a lot.
Well, thank you. I think you can hear me okay?
Perfect.
Well, thank you. I will say that it's always intimidating to follow Dr. Knott and then Dr. De Silva, and now I have to add Dr. Luciana to the list, but I will do my best. And because everything that I've learned about Ebstein, besides my mentor, Dr. Danielson, comes from these people. So we'll move ahead. I don't have any disclosures. A couple comments about anatomy. First, it's a spectrum, and the variability is infinite, and you can have anatomy that is not far off normal tricuspid valve anatomy, and then you can have situations where there is almost no mobile valve tissue present. And this is what makes surgical repair so difficult, because every patient is going to be different, and it makes getting comfortable with the procedure difficult when it occurs so rarely. And this is just an example, all different patients, and you can see here the enormous variability in the anatomy of the valve that the surgeon encounters, which makes surgical treatment quite difficult and frustrating at times. Conduction tissue, it's pretty reproducible. This little white spot here is the membranous septum. Obviously, on the other side of that is the aortic valve. The AV node is characteristically in this area of fat with the vein. You can see it here in a different patient. It's a relatively reproducible finding, and it's sort of the zone where you want to avoid suture placement during whatever your repair technique, or if you need to replace the valve this is obviously an area where you want to avoid suture placement. The coronary artery runs very close to the annulus, and in Ebstein, everything is very, very thin. So you can see here how vulnerable the coronary artery could be all the way around the majority of the annulus. And when you start out with an annulus like this and you end up with something that's going to be half the size or less, you could see how there would be a lot of potential for kinking or compromising or ligating the coronary artery, which cannot be emphasized enough. From a diagnosis standpoint, I think, at least in our practice here, I still prefer echocardiography for tricuspid valve anatomy. You still pick up other pieces of information, the position of the ventricular septum, the size and the function of the right ventricle, the size of the right atrium, and whether or not there's an atrial septal defect present. The 4-chamber view, to me, if you had to pick one money shot, that would be the money shot that is most helpful to me in terms of mobility of leaflet tissue, presence of septal leaflet tissue, the degree of displacement of septal leaflet tissue, etc. I think MRI is better as a better imaging study for analysis of the ventricle, particularly when you're trying to get a handle on the size of the functional right ventricle, versus the atrialized right ventricle versus the right atrium. I think we still are learning more and more about right ventricular remodeling, and I think MR imaging probably is the most objective, imaging modality to provide this kind of information moving forward. Indications for surgery, we've heard a lot about this now from our previous speakers, but in the newborn, I think if there's anatomic pulmonary atresia, if there's obvious congestive cardiac failure with ventilator dependency or failed medical therapy or persistent cyanosis, you're going to be roped into an operation. I think the previous speakers have summarized quite well what the options are. Suffice it to say that I think the decision of which direction you go still is program and surgeon dependent, and I would be careful about stating with any kind of dogma that one is clearly better than the other. I think it all depends on surgeon experience and program experience, and that's probably the correct answer at any given institution. When you get beyond the newborn, though, symptoms which are commonly not present, fatigue in my experience is probably the most common one, and it's something that could be very subtle. Sometimes noted by a parent, a little more naps with with their child in the afternoon, or coming off the soccer field a little bit quicker. But sometimes symptoms are not present at all, and you're relying on other information to determine the role of surgery. Cyanosis obviously is an easy one if there's an atrial level shunt, and in an infant if they're not gaining weight. For those that are supposedly asymptomatic, I think a formal exercise test could really shed a little bit of light on exactly how limited they are. But the fact is that we end up advising surgery more often on what's going on with the heart. And I think progressive increase in heart size is obviously something to be considered. If there's arrhythmias, either atrial or ventricular, either they become apparent or they progress. You really want to sort of do it before the right ventricle starts becoming quite dysfunctional. And I think in institutions where there's a good surgical track record, you could make an argument for earlier operation if you can provide a predictable, reproducible result. The treatment, of course, my assignment was to talk about the cone, which I am a believer in, and I'm indebted to Dr. De Silva, who really taught me all the basic principles. And we've heard a little bit about this from Luciana in the previous talk. I believe it's a near anatomic repair in terms of you end up with a functional orifice that is somewhere down in the ventricle away from the true tricuspid valve annulus. And at the end of the operation, you have a hinge point of circumferential leaflet tissue that's pretty close to the true annulus with elimination of the atrialized segment. The general principle is the surgical delamination process, which is the hardest process, I think, for surgeons to get comfortable with because there's a lot of attachments that get attached, and it can be quite intimidating to know exactly where to stop. But the way I try to explain it to the residents is the things that need to be maintained intact are what's going to the leading edge. Everything else needs to go, and oftentimes it's quite a lot of tissue. I get more questions about plicating the atrialized right ventricle. We'll see a short video of this, but it's the smooth, non-trabeculated area of the inferior wall. It's this area down here. And basically the plication is bringing these two orange lines together to get rid of this dyskinetic segment. And this is what it looks like in the operating room. We're looking into the right ventricle now, and we're sort of down at the mid-ventricular level, and you'll see the clear line of demarcation between what's trabeculated and what's not. And that's what gets excluded. And I would say you want to avoid going down to the ventricular septum, which is very easy to do because the ventricular septum is also smooth, but it's very easy to get the posterior descending coronary artery if you go down that far. So you really want to make sure that you're only excluding a segment of the inferior wall of the right ventricle. And the lines are really, they're mapped out for you just naturally. You can see the clear line between smooth and atrialized and trabeculated and relatively more normal function. And it typically extends right up to the atrioventricular groove and sometimes across the atrioventricular groove which helps reduce the size of the true tricuspid valve annulus so that it's smaller to match the size of the neotricuspid valve orifice. Annular reduction maneuvers, most of the annular reduction is inferiorly, but if there's a marked discrepancy, you might want to put multiple plication sutures around the annulus to avoid an exaggerated annuloplasty that could distort the right coronary artery. Modifications, I will say that, in my experience now, I use these less and less, but I think early on I have found them to be quite helpful. And so I will mention them to those that are trying to learn. The anterior leaflet can be quite shallow, and augmenting it with a piece of autologous pericardium that's untreated, I think really provides a lot of leeway in terms of getting leaflet coaptation. I look at this as increasing the height. You can see here the height between the original leaflet and the annulus is quite shallow in certain spots. And so increasing the amount of leaflet tissue really can be quite helpful. The second way of using pericardium is to increase the circumference of the cone. And in the beginning, when there's a lot of muscularized segments of leaflet tissue early on in your career, it's very difficult to utilize those segments. And so if you don't utilize them, you end up with a paucity of leaflet tissue that can make it very difficult to have enough of a circle to create an adequate size cone. So a triangular shaped piece can be quite helpful to compensate for that. Sometimes you end up with just a ridge of tissue with no chordal attachments. This is the septal leaflet. This is the anterior leaflet in a different patient. And I think once you mobilize it and you make sort of these autologous fenestrations, you sort of create what we refer to as autologous neochordae. This is a modified Sebening stitch. Dr. Knott talked about this earlier. In a neonate, it's very, very easy to just take the papillary muscle and sew it right to the septum because the distance between the papillary muscle and the septum is very short. But in an older patient or in an adult where the distance is quite long, it ends up being the equivalent of sewing the anterior wall to the septum. And that is a lot of tension and it'll come apart. So this modification, when you have a trabeculation or you have a prominent septal papillary muscle, it's nice to sew the heads of the papillary muscles together, even this papillary muscle being mobilized a bit, so you avoid tension on the right ventricle where this will dehiss, which happens commonly in older patients. Bands are helpful. I will say that it's probably most helpful inferiorly, where you have the plication suture line and you have the inferior annular plication present because there's a lot of tension. It could be fabric, it could be pericardium, it could be a little piece of a ring. It's up to you. The need for a more complete circular band is up to you. We used it often early on, but I think now with reinforcement of suture lines, it becomes less essential. But I think inferiorly is where the greatest tension is. And so if you're going to reinforce one area of the annulus, that would be the area that I would choose. This is a patient that we operated on, and you can see here all of the points of tethering. You can see not a lot of mobile septal leaflet tissue, and of course you can see a lot of tricuspid regurgitation. So this is an intraoperative video of a lot of the things that we've talked about now: aortic occlusion, cardioplegia, right atrium's open. The anterior leaflet is being incised off the annulus. And a lot of these muscular and fibrous attachments need to be taken down. The assistant really is quite helpful here in terms of showing the plane clearly, which needs to be mobilized. You can see some inferior wall down here that's atrialized. We'll come back to that later. You can see here now continued mobilization. We're working toward the septal leaflet right now, which is quite shallow, but you can see it's got good chordal support, and it really needs to be mobilized. This is the plication. Again, you can see it's pretty reproducible, the smooth non-trabeculated areas. You can see the line of demarcation up here, and you'll notice that I'm not going far down because this down here is smooth and that's septum, and you want to resist the temptation to go all the way down there because it will be very easy to get a coronary artery. And I do it in 2 layers just because I'm conservative. And again, the bites do not need to be deep. They're mostly endocardial. And you can see here how it comes all the way up across the true annulus. And it's very important to inspect the exterior surface of the heart to make sure that coronaries haven't been compromised. And then once we've done that, we go back. Now, this is an example of a patient where we thought that the addition of a piece of pericardium would be helpful to increase the circumference. And you'll see here, this last point of attachment I'm going to leave intact just to sort of help set it up, and then we'll divide that later, but that's a temporary thing. So you can see one side of the triangle of the pericardium is sewn to the proximal mobilized edge of the septal leaflet here. I used to do this with interrupted stitches. Now I do it with a running stitch, but it's very easy to purse string it. So before it gets tied, you know, the assistant needs to sort of separate the suture line out so that you don't shorten the width of the leaflet, so to speak. And then the other side of the triangle is going to come up to the anterior leaflet. There's really no inferior leaflet here at all. And again, we do the same thing and march from one corner up to the orifice side of it. I usually do a running locking stitch. It's a very fine stitch. It's 6/0 in infants and small children if needed. It's 5/0 in an adult. So it's really fine suture. And then we'll cut this last attachment right there once we've got this sort of circle made. And you can see here now that it's starting to take shape, and I'm putting a tacking stitch right here, again, staying apical to the conduction tissue, which is going to be right in this area right here. And so the neoseptal leaflet is pericardium now in this case, and it's we're marching along just distal to the conduction tissue. And I think you sort of have an idea of what of how this is all sort of being teed up. And once it's set up, it goes along relatively smoothly, meeting the suture line where the atrialization part. You can see here now what's going to be left, and the reattachment again is with continuous suture. And the purse string effect on the annulus does tend to make the annulus smaller. And we do usually, you know, tie this down over a Hagar dilator just to be sure that we don't create any iatrogenic stenosis. And then the suture lines meet here, and you see the complete reconstruction sort of coming into focus here. And once this is completed, we will obviously examine the valve. And at that point, you can see all these suture lines. This is why it's a little tricky to decide whether or not you want to do this in a neonate where the leaflet tissue is nothing like what we're working with here now. A couple miscellaneous fenestrations that are going to get closed. And then we will move to this is an echo now 6 months later. And you can see here that when this operation works, it really works beautifully. And this is one of the reasons why we've adopted it uniformly. From a results standpoint, we have a lot of experience with Ebstein surgery. We're now over the 400 mark at this point in time this year. This was a year ago. Mortality is very low. The ages from infants to adults. This is the first 235. I would just make the point here that I was fortunate to have the patience of my cardiology colleagues because the learning curve is challenging in the beginning. You know, there was a fair number of patients that were going back to the OR before they got discharged. It's a combination of just being timid with bites and just learning from your own experience. But even now to this date, there's an occasional patient that goes back, but it's much less frequent. Mortality has been very low. We pretty much don't turn anybody down for surgery, so there's a lot of difficult ones that come our way, and so ECMO's been required in some. Delayed sternal closure, these are for sort of the salvage cases. It's not that common now. We have a lot of experience now with re-repairs and re-repairs that are up in the 30 to 40 range. You can see here the bidirectional Glenn was more common in children than it was in adults, but I would say now in the second, 150 to 200 cases, it's probably about 10%. It still takes me about an hour plus to do this properly. So it's even with a lot of experience, it still is a time-consuming operation. But the hospital stay has been good. The degree of tricuspid regurgitation has been very favorable for the majority of patients. There still are some that are difficult, that are hanging out there with recurrent TR that are going to come back. And the freedom from reoperation, at least at the 5-year mark, has been really quite favorable. I think considerably better than what we were doing in the earliest era. Everybody asks about atrial septal fenestrations. It provides a right to left shunt that gives a little preload to the left ventricle, but it really does not unload the right ventricle. The penalty is a little cyanosis, and remember that that is an indication for surgery in some patients, so keep that in mind. In a neonate, I think it's a no-brainer if you're doing a biventricular repair to leave it behind. I think in infants in general, it's a good practice. In older patients, you got to be careful. You got to make sure that they actually would shunt right to left, and some of them don't, either because of LV function or longstanding hypertension and elevated left-sided filling pressures that may actually be detrimental. The thing about the bidirectional Glenn that really makes it quite effective is that it really unloads the right ventricle by a substantial factor. And so you really avoid the low cardiac output issue that you might not get with atrial septal fenestration, because it really provides great preload to the left ventricle. And I think early on in your career, when you're trying to learn how to do the cone procedure, this allows a little more forgiveness. And so keep it in mind. The indications in our practice have been mostly an enlarged dysfunctional right ventricle. When you see the left ventricle really pancaked and D-shaped in the short axis view, this is kind of a soft indication. Dr. Hanley has proposed this, quite a bit more. In our experience, we've not been so religious about it. This is a very helpful maneuver. If the RA pressure is more than 1.5 times the LA pressure at the end of the operation, it really suggests that the right ventricle is struggling, and a Glenn may be helpful. It does reduce tension, and it's also helpful if you have a small effective orifice to get rid of the gradient. Separation from bypass is very deliberate and intentional. I'm quite have strong feelings about it in the OR. It's a slow separation. It's an epi-milrinone combination. Vasopressin seems to be helping in some situations. I think we found this with many right-sided heart failure patients that may or may not be related to liver congestion. Volume administration is done carefully, and my preference is a single-digit central venous pressure, but generally not in the teens. I really don't like these volumes tested with volume, because you really can start pulling suture lines apart. And also for the same reason, I like fast heart rates to keep the right ventricle small, and then do the TEE with a physiologic blood pressure, because the echo always looks a bit better in the operating room than it does on the discharge echo. And when the cardiologist is doing the echo, just remember that when you do the cone, you end up with a complete circle of leaflet tissue. And the gradient needs to be determined at the apex of the cone, not at the level of the annulus, because this orifice is generally going to be smaller than it is at the true tricuspid valve annulus. And regional wall motional abnormalities in the left ventricle cannot be ignored. It generally indicates a coronary problem. And do not dismiss it. You'll get burned. And ventricular tachycardia is basically a sign that there's a coronary problem, and you need to pay attention to it and decide whether you're taking something apart to correct that. In the ICU, we wean inotropes slowly. They can get this low cardiac output syndrome, within 6 to 12 hours. They all have a metabolic acidosis. It's probably in part iatrogenic, because we're running them hypovolemic and tachycardic. So the lactates can go up to 7, 8, 9, 10 sometimes, although their blood gases are generally show a corrected acidosis. But once we see the lactate stabilized or starting to come down, we extubate. We avoid transfusions. Some type of afterload reduction is helpful, although there's not a lot of evidence for ACE inhibitors on the right side. It may be helpful in patients where you're really worried about the right ventricle. A short course of sildenafil to reduce the afterload of the dysfunctional right ventricle can be helpful. Beta blocker therapy and amiodarone therapy, I think, is used selectively in patients, particularly if there's any history of arrhythmias. If we use a pericardial patch, we do use warfarin for a short period of time. In children, we'll probably just go with aspirin, but in adults, we have seen some clot on pericardium, so we tend to use a short course of warfarin. And I think late exercise testing and lifelong surveillance cannot be overemphasized. These patients do develop problems down the road. So with that, I will stop, and I will all try to answer questions. Thank you for really a wonderful seminar, and thank you for the very kind invitation to participate.
Thank you. Thank you very much. It was amazing, and I'm very happy to have these three very good speakers to talk about this very interesting topic. And I can't wait for the discussion that is going to be in the end of the session. So if you all can stay until the end, we hope we have time for discussion on this topic. And now we are going to move on. We are going to have a very interesting topic with Dr. Shi-Joon, and he is a cardiac radiologist at Sick Kids, professor of the Department of Medical Imaging and Pediatrics in the University of Toronto, and his main clinical and research activities are MR and CT applications in children with cardiovascular diseases and fetal echocardiography. He is an early adopter of 3D printing in pediatric cardiology and surgery. This technique allows preoperative assessment and simulation of the surgical procedures in patients with complex congenital heart disease, morphology techniques, morphology teaching, and hands-on surgical training. We had a meeting with him a couple of weeks ago, and it was very interesting to see how HOST works. This is a very nice initiative, and we are very happy to have you with us today.
Thank you very much, Grace, for your kind introduction. And then they also very thankful to the Congenital Heart Academy support our program. The Sasha and the Grace, you were very kind in including us in your kind of a big territory of network and for the tremendous educational value. So what I would like to do in the last 10 minutes is that our hands-on surgical training program, which will be held at the end of November and early December this year. I don't have no disclosures. So the 3D print motors, were first used in the 2015 AATS when Dr. Pedro Del Lido was the president of the society, and then Earl Austin was the program director for the hands-on course. And we had a great opportunity to provide the old motors, and then Glenn Van Aster as the primary proctor of the meeting. So these are the first year the operation on 3D print motor for this course, Glenn Van Aster was doing, and then we made some first trial of motors for the course. We made the 180 motors for 60 surgeons for this course. And then after that, this is a scene of that first meeting with the 3D printed motors for hands-on the surgical training. So immediately that we found that this is really valuable. So we began to organize the hands-on surgical training. We named as a HOST in 2016. And then we did the 5 courses up to now, until last year. And then we began to incorporate the hands-on surgical training for our own trainees, the monthly base. Okay. So I wanted just to show that one video clip. This is a video clip made by Nabil
Simulation
Hussain,
provides surgeons with a safe platform to rehearse and deliberately practice congenital heart surgical procedures.
Surgical fellow. Okay.
Here's a clip taken from the training video of the arterial switch, performed by one of our staff surgeons. Each training video is 5 minutes long and focuses on the technical aspects of the procedure and can be referred to by our trainees during their rehearsals. We feel this is advantageous as it takes away the physical need for the staff surgeon to be present, enabling the trainee to practice in their own time. On the left, the surgeon is rehearsing the arterial switch procedure the day before they perform the real thing, which is shown simultaneously on the right. The fellow had performed the arterial switch 4 times prior to the real operation. Here the fellow is carefully excising the left coronary button with particular care paid to the aortic valve, which is also included in the model. Here the same technique is used to suture ligate and transect the PDA. You can see how the exposure and the positioning of the surgeon is identical in both videos. The pulmonary artery is then incised and the orifice of the branch PAs is carefully inspected prior to completing the transection and mobilization. Following the LeConte maneuver, the neo-aorta is reconstructed with the suture commenced along the posterior wall of the aorta. The reimplantation of the coronary artery is technically the most challenging aspect of the arterial switch. The method used here is the closed technique with medially based trapdoors, where and how to make the incision in a safe manner and to ensure the correct position and orientation of the coronary is crucial when performing this step. The fellow has repeatedly rehearsed this technique, so when it comes to performing it in reality, it is done with maximum efficiency. The trimming of the button is done in the same method, and the anastomosis is completed. In both cases, the fellow has been assisted by the same staff surgeon. We have found that hands-on simulation is also advantageous to the staff surgeon, as they're able to coach the fellow in an environment without the pressures of the OR. The staff is able to critically evaluate and provide active feedback, and is able to identify the strengths and weaknesses of the trainee and plan the course of the operation. Here, the fellow completes the reconstruction of the pulmonary trunk. It can be technically challenging to ensure that the patch is the correct size and shape to avoid compression of the coronaries or create a gradient through the reconstructed vessel. This again can be rehearsed on the model. Within our simulation program, we use 3D printed patch material with a thickness of 0.8 millimeters to closely resemble the pericardial patch. We found this to be more advantageous than bovine pericardium, as it allows the surgeon to keep the model for feedback purposes. Excess patch following the reconstruction is trimmed to ensure the correct height with the native tissue. The reconstructed pulmonary root is then anastomosed to the branch PAs, which is shown here. Here we see the end result following the final repair on the model. From this lateral view, we can now see that the reconstructed neopulmonary trunk is anterior to the neo-aorta. From the superior view, we can see the correct lay of the coronary arteries without any stretching or kinking. The whole procedure was completed by the surgical fellow without significant assistance or guidance from the staff surgeon. The patient had an uneventful course, and cardiopulmonary bypass and cross-clamp time were acceptable. Following successful cases like this, we have further increased the utilization of 3D printed models to prepare our surgeons for complex congenital heart procedures, and have now incorporated an in-house hands-on surgical training program as part of our congenital cardiac surgery curriculum. As training opportunities remain limited and expectations continue to grow, this provides an effective method to augment future training.
So we have here about 50 the models available for any kind of congenital heart surgery, except for the pulmonary vein surgery. And unfortunately, we are working on the model for the Cons procedure. But anyway, we have a quite significant number of models available. Then we developed try to make the video guidelines for each procedure. And then finally, we think about how to assess the outcome of training. So we developed the evaluation tools, which was published this year in Journal of Thoracic Cardiovascular Surgery. So it consists of two parts. One is that the procedure is divided into multiple levels, and then grade is yes and no. What it means is that you're successful or unsuccessful. And then each procedure has the grade of importance, and then multiply that to make the score. And then we found that this score was far better than existing scores. Okay. And then we are using this for the really evaluation of the improvement. So we asked the attendees of host course, do the arterial switch operation twice, and then we assess the score. The first the assessment is on the time. It's the first attempt of arterial switch operation. This is the second attempt of arterial switch operation. You clearly see speed is much improved. And the second is that the score of the outcome. So you can clearly see the variation among the individuals narrow down, and then there is pretty significant improvement of the scores. So based on that, we continue to do this course. This year, unfortunately, because of the COVID, we are not able to host the 6th course. And then we decided to do online 2 times to attract people from over the world. And then one is in November 28 and 29, and the other is December 5 and 6. The course is exactly identical, but we repeat twice. So this is a form of online. So we can't accommodate more than 10 people in one screen to supervise it. So we make it into 3 classes. So which means that one session, we're going to have 30 attendees, the applicable. Fortunately, we had the support from the previous outpatient, Peter Butler, who was the patient of Dr. Bill Mustard and got the operation of his tetralogy fellow. And he's a successful businessman. He see that our program very useful for training, and he decided to support the models for the surgeons in training status. So the course, there are 2 times, as I mentioned, main hands-on course, November 28, 29, and December 5 and 6, a little bit different time. And then there will be 3 cases, the hands-on. One is that classic transposition with normal, usual coronary artery anatomy. The second is the transposition with the left anterior descending from usual position, however, common origin of right and circumflex from the sinus 2. And then lastly, having a Tausig ring malformation. The whole the session will be preceded by priming session, the didactic lectures on the morphology, imaging, and surgery. So we're going to have 3 proctors, Dr. David Barron, Osami Honjo, and the Glenn Van Aster from UCLA will join us to teach all the 60 attendees. So the attendees, we're going to send the motors like this to the attendees, and the attendees can fix the motors with the plate here with the plasters and do the surgery here. Also that we have the operation and the chest wall simulator, as shown here, that can be purchased on the attendees cost. We have a little bit new approach this year. So we are interested in making silicone-based model. The reason why it is interesting is that silicone is far better than currently available print material. So it is more realistic surgery can be reproduced with the silicone. So these are the pieces of silicone. What is that? AV valve, arterial valves, and aorta and ductus and the ventricle in 2 pieces, and all together, putting together, we're going to make the motors like this. And then you're going to have full myocardial simulation, and then aorta and pulmonary trunk and PDA, and then coronary arteries here. The fat layer is simulated, so it is far more realistic than we previously had. Unfortunately, we don't have all 3 available, so 2 will be in this form, and 1 will be with the traditional, the 3D printed motors. So anyway, that we are all ready to host it. Deadline for application for this course is in a week, September 30, and then we'll take the application from anybody in the world, and then trainees for the congenital heart surgery, we're going to have a priority acceptance, and then residents will be in the waiting list. and then even the staff physicians, surgeons can apply for this course. Okay. So we believe hands-on surgical training is really mature enough, and then it's proven feasible and applicable and powerful. I wish that all the surgeons there throughout the world take the opportunity to use the models we generate. Thank you very much for your attention.
Thank you. It is really interesting. I found it very, very interesting, and I hope a lot of people can benefit of this training. So our next speaker doesn't need introduction, is Dr. Sano, who is going to talk to us about Norwood Sano. Thank you very much. Dr. Sano, can you hear me? Good. Now we can. Good.
Can you hear me?
Yes, we can. Thanks very much for being with us. Can you share your screen?
Right.
Good morning, everyone.
We can't see your screen yet.
Yeah, I haven't started yet.
San Francisco time is hang on.
Is that green button on below your screen?
Yeah.
On your Zoom window. You click on that, it's going to open another window, then you click on your presentation.
Sorry. Okay.
No, we can't see you yet. So
good morning.
We had two screens.
Can you hear?
We can hear you, yes.
You cannot hear?
We can. We can hear you. Yes, and we can see you, but we can't see your presentation.
Is it? Oh, here.
Yeah, so on this screen, yeah.
Can you see my slide?
Not yet. So you need to share your screen on this computer that you are now. Not on the other one. You have two screens, right? Now we can see it. Amazing.
Can you see?
Perfect. Yeah, just go to presentation mode on the PowerPoint. Perfect. Thank you very much, Dr. Sano.
Good morning. Now San Francisco time is early in the morning, so I'm probably sleeping. So take a time. My topic is how to improve long-term results and the quality of life of hypoplastic left heart syndrome. My 30 years challenge. I have no disclosure. So since the introduction of surgical palliation in 1981 by Norwood, survival of children with hypoplastic left heart syndrome has dramatically improved in stage reconstruction for the last 2 decades. Right. This is the result at Children's Hospital Philadelphia. A node survival rate has improved since 1985. However, mortality was still over 30% at late 1990s. This is a result reported from various excellent units. Interestingly, the results from these units were similar, with a survival rate of 60 to 70s. My experience at Royal Children's Hospital was terrible, even by Roger Mee and Bill Brown's excellent technique. Every time node operation is fine, blood pressure, saturation are fine, but whenever diastolic pressure dropped below 30 to 25 millimeter mercury, the baby suddenly collapsed. So there's only one success case. So that this was the same in neocomers from my hands. So I thought the too low pressure diastolic pressure is the problem. So how to increase diastolic pressure to prevent sudden circulatory collapse. Then I thought the classical node is to change the aortic atresia to pulmonary atresia. So if we change the aortic atresia to pulmonary tetralogy follow, there's no diastolic runoff into the shunt. So diastolic pressure should be higher. So this is the classical node, and the right side is the RVPA shunt. So we did the first RVPA shunt in February 1998 using 5 millimeter PTFE graft. And I published the data to Journal of Thoracic Cardiovascular Surgery in 2003 with 19 consecutive series with 4 patients reached to Fontaine. There has been always a debate which procedure is better, either a modified BT shunt or RVPA shunt. The single ventricle reconstruction trial was conducted in North America. They reported RVPA shunt group has a better result in 4 years. However, there was no significant difference. The survival SVR trial also showed 4-year survival of RVPA shunt is better than the classical node with BT shunt or hybrid procedure. Although the survival rate is better in RVPA shunt, there was a disadvantage of RVPA shunt, which is the more shunt stenosis compared to Norwood with the BT shunt. There has been always debate which procedure is better, only the blood source. But there's another important point in node operation and how to reconstruct neo-aorta. Post-operative reconstructed arch can increase the afterload and decrease ejection fraction. Decoarctation increase the afterload. Artificial material decrease vessel elastic properties, increase wall stiffness, and decrease distensibility. Also turbulent flow increase wall stiffness. To achieve better long-term outcome and quality of life, we have modified our technique to avoid arch obstruction and keep elasticity and the smooth pathway of neo-aorta without patch materials, and avoid PA stenosis using ringed PTFE graft using dunk technique and minimize ventricular dysfunction to create RV hole using coronary puncture and aggressive treatment of tricuspid regurgitation and avoid overflow using the clip on the PTFE tube. My mentor, Bill Brown, mentioned that the next challenge in pediatric cardiac surgery is to minimize brain damage. In 1970s, my another mentor, the Sir Brian Barrett Boyce, popularized repair of complex congenital heart disease using deep hypothermia circulatory arrest using a Kyoto technique. This is an excellent technique to protect not only brain, but also the whole body without circulation. However, brain damage increases with time, especially over 60 minutes, and the neurologic, developmental, and the psychiatric abnormalities are found in some of the survivors. Now, I have experienced these findings in Green Lane Hospital when I was a fellow. This experience came up with the cerebral perfusion to avoid deep hypothermia circulatory arrest and keep cerebral perfusion during arch cardiac surgery. We have developed isolated cerebral and all myocardial perfusion. That means the antegrade cerebral perfusion or antegrade cerebral and also the myocardial perfusion to prevent, to avoid deep hypothermia circulatory arrest and also keep cerebral and or myocardial perfusion during cardiac surgery. Since 1995, we have been using antegrade cerebral perfusion or cerebral and myocardial perfusion to all the patients with arch repair. Our bypass strategy during arch repair in Norwood modification is to use antegrade cerebral perfusion using PTFE graft anastomosed to the innominate artery. But our recent technique is to perfuse whole body using another arterial cannula to descending aorta through duct. Systemic cooling to 26-28 degrees centigrade with moderate hypothermia. We normally use deep hypothermia. High flow cardiopulmonary bypass. During cooling, main pulmonary artery is divided in triangular shape to keep proximal main PA tissue as much as we can. And the main PA posterior bifurcation part is plicated and the linked PTFE graft with PTFE cuff is anastomosed to the distal main PA during cooling. The RV hole is created underneath a pulmonary valve with coronary puncture to minimize RV damage. Under cerebral perfusion, the aortic arch was opened inferiorly and this incision was extended down into the ascending aorta to the level of the transected end of the main pulmonary artery. The aortic arch and ascending aorta just opposite side of the innominate artery were sutured inferiorly to extend the width of aortic arch and shorten the neo-aortic suture line. This plication shifted proximal aortic arch inferior And this distance between main PA and the arch become shorter by this technique, which makes direct anastomosis of aortic arch easier. The coarctation tissue is all excised. The neo-aortic arch and descending aorta is anastomosed directly. Initially, the aortic arch reconstruction was performed without any patch materials. However, we found recoarctation rate was more than 20% in this technique. So we gave up this technique. Aortic arch reconstruction without patch materials was possible in 60%, and a small pericardial patch was needed to reconstruct the neo-aorta in 40% of our patients since 2012. Since then, with bridge, using this bridge technique, we have no recoarctation. After aortic arch is reconstructed, cross clamp is removed, ringed PTFE graft is inserted into RV hole with double predated mattress sutures around the hole, so-called dunk technique. Using ringed PTFE graft with dunk technique, proximal conduit obstruction became very rare. Risk factors for overall mortality, a body weight less than 2.5 kilogram, premature birth, and associated with intact atrial septum or restricted ASD, TAPVC, and a modern mild tricuspid regurgitation. From January 2008, we adopted new strategy to these high-risk patients. We do a bilateral PA banding and infuse PG1 to keep duct open. A node Sano operation was performed 2 to 4 weeks after bilateral banding. The current status of all cases, stage 1 survival rate is 92%. And the overall survival is 75%. The current status of a normal risk hypoplast is the survival rate after stage 1 is 95%. And the overall survival at median follow-up time of 8 years is 87%. The recent advance in the surgical management of hypoplast has dramatically changed the clinical outcome. However, Fontan circulation exhibit the number of physiological limitations that have a negative effect on organ system development and the functionality. The prevalence of systolic and diastolic ventricular dysfunction continues to increase after Fontan operation, particularly in those morphological right ventricle. A recent study has shown that the hypoplast have strongly associated with adverse event and the late failure. So we started cardiac stem cell therapy at Okayama University since 2011. RA tissue was harvested during bilateral grain or the Fontan, and these tissue were isolated and cultured for 2 to 3 weeks. And and then these cells are injected intracoronary directly by cardiac catheterization. Global cardiac function improved markedly at 1 year after CDC infusion. That continued over 3 years post-cell infusion. The CDC treated group showed lower BNP level at 3-year follow-up, and also the weight for age were significantly higher in the CDC treated group than the control group. This is our annual hyperplus left heart syndrome cases and strategy. We have 4 to 10 hyperplus patients per year, but recently we have more high-risk patients from all over Japan. So in summary, stage 1 survival rate has been increasing, and recently many centers they have achieved a survival rate of more than 90%. And there has been many modifications in Sano procedure in 20 years, and these modifications contributed improvement of long-term survival. The rapid 2-stage Norwood procedure is recommended to high-risk patient. The positive result from stem cell trials and a clinical breakthrough for cardiac regeneration therapy to the patient with heart failure in hyperplastic left heart syndrome and single ventricle. Although there are many hurdles to overcome, the future outlook for cardiac regeneration in children seems bright. Thank you very much for your attention.
Thank you, Shunji. It was, again, a really big update, and mostly of the people are now thinking about regeneration thanks to you, thanks your vision to the congenital cardiac surgery. So thanks again, but now we have the last speaker. She's a colleague, she works in Italy. She's my real privilege to introduce Emanuela Angeli. She works in Sant'Orsola Hospital, it's a university hospital in Bologna, together with Gaetano Gargiulo, and we are very proud of the experience that they develop in aortic arch reconstruction. So Manuela, if you can share your screen and you start your lecture. Thank you very much.
Thank you.
Thank you very much. It's a great pleasure to be here with you all, and lots of important surgeons talked before. Thank you, Sasha, for the opportunity. So let's move to what is aortic arch reconstruction. Sorry. I think that I would like to start with a paradigm to explain the philosophy of aortic arch repair. I think that we have to keep in mind 3 main points, and these points are represented by the anatomy, because it's mandatory to have an accurate definition of the anatomy of the aortic arch. The surgical strategy, because especially in this type of repair, the surgical approach can be different for each patient. If you imagine that this surgery can have a thoracotomy approach as well as a sternotomical approach, and that there are really different types of surgery for each type of anatomical anomalies of the aortic arch. Last but not least, one main point of this paradigm is the organ protection. Today, we are going far away from deep hypothermic circulatory arrest, And we are really inside of other intraoperative strategies represented by cerebral protection, myocardial protection, combined cerebral and myocardial protection. So what we'd have to say is that aortic arch anomalies are a wide spectrum of conditions which can also be associated with other complex cardiac defect. Is it all? Well, yes, we can see here that we can go from the anatomical point of view from simple isolated coarctation to different grade and type of aortic arch hypoplasia, and then even much more complex form, anatomical complex form that are represented by the interrupted aortic arch. But we cannot forget that this surgery is performed in prevalence in the neonatal age. So as far as the surgery is going to do a one stage and a perfect repair, we have to face with low birth weight patients and that have even in case of a normal gestational age, organ immaturities that plays a crucial role in this repair and in the outcome of this repair. Here we have we saw already really complex aortic arch repair, and just of course Professor Sano showed everything about aortic arch repair in hypoplastic left heart syndrome. This is only to show that we can trim down from the complexity and going to talk about a different type of surgery. Let's start with the aortic coarctation with aortic arch hypoplasia. These two pathologies, if we can consider them differently, are often together, present in neonates around in 81% of cases. The aortic arch can be presented with a large spectrum of anatomic variants in terms of extension and in terms of size. From the surgical point of view, the approach are as well various because they must be tailored for each patient. I loved this review, this paper of Becker, because it's so, well, a surgeon search for the holy grail. Well, it is a little bit like this. We look for the perfection. We didn't already found it. But if we have to define the hypoplastic aortic arch, you have to keep in mind that you have, in my opinion, three main points. The size of the arch in millimeters is less than the patient weight in kilogram plus 1. The aortic arch diameter zeta score is inferior to -2, and the ratio of the diameter of the transverse arch to the descending aorta is less than 50%. So just to have an example, if you have a 2.5 kilogram patient, you can expect to have a hypoplastic arch when the diameter is less than 3.5 millimeters. We have isolated coarctation, but as I told you, we can have long isthmus hypoplasia, distal arch hypoplasia with bovine trunk, or extensive arch hypoplasia. And the approach to this surgery is different. So as you can see, I tried to summarize the surgical variables are enormous, but now what is used in prevalence as a surgical approach is represented by the end-to-end anastomosis and the extended end-to-end anastomosis. The interposition of patch, or rather than the reverse flap of the subclavian artery, has a lower impact at the moment, has demonstrated by this very interesting multicentric study that I suggest you to read, because here you can find more than 5,000 patients. The prevalence are neonates, and the different approach of the aortic arch reconstruction. And as you can see, the prevalence, even in this huge experience, is represented by the end-to-end anastomosis and even more by end-to-end extended. This paradigm, in my experience here in Bologna, I just want to put you in the decision making that we have. We studied, and in our unit, the School of the Aortic Arch developed all over the years. And the anatomical point of view, then the anatomic type of these anomalies has conditioned also the approach, as I told you, and during the years also the perfusion strategy. What do? We have two different approaches. Thoracotomy for isolated coarctation, for coarctation and distal aortic arch hypoplasia, coarctation with distal aortic arch hypoplasia associated with isthmus hypoplasia. In these cases, we perform the thoracotomical approach. When we use sternotomy, the sternotomical approach, in coarctation with complex aortic arch hypoplasia or associated with congenital heart disease that deserve and can be repaired in a single stage surgical procedure, or in case of interrupted aortic arch. Even in this group of sternotomy, we can make a difference with patients who require cardiopulmonary bypass and those patients who didn't require and are selected cases. So let's move and see what we do. Classical coarctation with the distal aortic arch hypoplasia, we perform end-to-end extended anastomosis. And here is our approach. Third space in the thoracotomy, isolation, the extensive isolation of the aorta, the vessel. And here you can see that the aortic clamp is pushed a little bit far in order to have the best extension of the anastomosis. Here we remove the ductus tissue, the ductal tissue. It is an extensive removing, an incision in the aortic arch concavity, and a small incision of the descending aorta in the posterior wall. And here you can see the direct anastomosis. Of course, there is always space for other type of repair through thoracotomy, the reverse flap associated with end-to-end anastomosis, or the new roof technique. It means when left subclavian artery and left carotid artery are anastomosed, and then end-to-end anastomosis is performed. I told you what we do for sternotomy, and we can move directly for our experience. Here you can see a selected case of patient with a long hypoplasia of transverse arch and bovine trunk, He also had a the associated VISD. And in this patient, we decided to have a sternotomical approach, so through sternotomy, but without cardiopulmonary bypass. And you can see here that the control was absolutely perfect of the innominate trunk. In this case, you can see already prepared the bending tissue. What is the advantages of this approach? Of course, you can have a better vessel exposure, the possibility to switch on cardiopulmonary bypass if you need it, and the better positioning of the pulmonary artery bending. Professor Sano already said something about strategies of cardiopulmonary bypass strategies. Since 1997 in our unit, we completely abandoned the deep hypothermic circulatory arrest. So what we do during cardiopulmonary bypass, we repair aortic arch under moderate hypothermia. It means between 26 and 28 degrees. Antegrade cerebral perfusion, myocardial perfusion when possible. All patients are monitored with the cerebral and renal probes. The cardiopulmonary bypass flow is maintained around 150 milliliter kilogram minutes. The flow of the selective cerebral perfusion is between 20 and 40 milliliter kilogram minutes in order to maintain a main arterial pressure of between 30-40 millimeter of mercury. The hematocrit is maintained between 30 and 35, and we use continuous ultrafiltration. As already said, we believe that this selective organ perfusion is really important in neonates because it avoids a deep hypothermic circulatory arrest, so deep hypothermia, and avoid and protect the organ's immaturity. So this strategy admit to guarantee adequate perfusion during aortic arch reconstruction, minimize myocardial ischemia, and maintain moderate hypothermic cardiopulmonary bypass. And here you can see what we do. Sorry, let's go here. You can see the monitoring, renal and renal probe before the cerebral probe for the ears. Here the cannulation of the ascending aorta and the proximity of the innominate trunk. Here you can see on your right, you can see a line built especially for this type of reconstruction. 2 cannula, once also put in the ascending aorta. The closure of the ductus. Huge dissection of the thoracic aorta in order to mobilize the tissue. The clamp is positioned in the descending aorta. And here the clamp is positioned in the aortic trunk, means subclavian, carotid, and artery in the left. This clamp in the ascending aorta, now we start the myocardial, and with this clamp, the cerebral selective perfusion. The ductal tissue is removed. the heart is beating and we control ACZ variation and blood and the VO2 saturation. Here a small incision of the descending aorta and a large incision of the concavity of the ascending aorta, of the arch to the ascending aorta. The direct anastomosis, we completely avoid the use of prosthetic material in this surgery. The pressure is maintained between 30 and 40 milliliter of mercury. The flow, okay, and this is. What do we do in case of an interrupted aortic arch? The anatomical point of view, you all know the classification and you know the three types of type A, type B, and type C of interrupted aortic arch. This is a case of, in type B, interrupted aortic arch. Here you can see the interruption. Cerebral, the cannula, the arterial cannula are positioned as before, one in the truncus and the second one you can see in the ductus of Botallo. During the cooling, we arrive in this case at max of 26 degrees. The patient now, we removed the cannula of in the Botallus ductus, and the heart, the perfusion of the heart is guaranteed with another cannula positioned in the ascending aorta. After the dissection extended of the descending aorta, the anastomosis, the clamp, of course, the clamp is positioned in the descending aorta, and the aorta is reconstructed, the arch is reconstructed with an end-to-side anastomosis. Since 2017, we performed around 216 patients for aortic arch repair. Here are not included the case of with the associated complex cardiac defect. And you can see here that, in prevalence, we performed surgery through thoracotomy. One of the reasons is that during the years, we became probably more aggressive and with end-to-end extended anastomosis. And the mortality in this population, the overall mortality, is 2.7%, with an increase, of course, in the form underwent repair with cardiopulmonary bypass. What do you think? What you have to keep in mind, I think, talking about aortic arch surgery? Aortic arch surgery must be safe, must be definitive, must be anatomical, without the foreign material use, and especially, as you can see in this case, with aberrant subclavian artery, tailored for each patient. To gain this result, we need to have accurate definition of the anatomy. Before going to the OR, the surgeon must know which type of aortic arch anomalies the patient have. which type of approach is better for the patients. The surgery must be tailored, and it has to guarantee an accurate organ protection. As told before, it's true, the experience of the surgeon and the team, especially of the perfusionist, is crucial. So, back to our paradigm. Aortic arch repair must have now a low mortality, a low morbidity, so avoiding ischemic brain injury, spinal cord, abdominal organ injury, because we know so much about organ protection. There must be a low incidence of recoartation, and we have to think about optimal arch remodeling. In the follow-up, we can verify this, because now we know exactly how much the geometry, the flow pattern, the wall shear stress can influence the results of this surgery. Oh, sorry. Okay. I believe that a combination of selective myocardial and cerebral perfusion is effective in aortic arch repair and has the same important role of the surgical technique, because you have to guarantee an adequate organ protection, especially in neonates, and minimize the injury of immature organs. In case of complex aortic arch and intracardiac anomalies, the possibility to use combine selective cerebral perfusion, selective myocardial perfusion, and then myocardial ischemia during the repair of the intracardiac lesion can reduce significantly the ischemic time of the myocardium. One more word. Here we don't talk about complication, is not the time, but we don't have to forget that the recoartation can arrive in this patient, and they deserve a very strict follow-up. Thank you very much for your attention.
Thank you, Manuela. I think that was a very re-epilogative, and the School of Bologna is a very, as you say, a school of aortic surgery, not only for Italy, but I think for most of the world. And we are very proud to have this school in Italy, to have you and Gaetano Vargiulo working together on this. And these topics was amazing. I'm sure that mostly of the people who's looking at him now have more clear, and your experience also offer a lot of point of discussion. The only thing is that today we reach the maximum hours. We are out of the 3 hours. So it's, I don't know if Grace is here and all the speaker is here. Yes. We would like to thank you, all of you, very much. I think that it's, as we exchange with Manuela, in this moment, it's very impossible to have such of type of information every week, or sometimes 2 times per week. I think a lot HISASHI, NIKAIDOH, that we want to come back again in Taormina for a visit, but we don't know when it will be possible to happen. We thank Professor Craig, Knott Craig. It was a real pleasure. Thanks to be with us. Luciana da Fonseca. The topic of Ebstein is something we consider like a neoplastic disease for the child sometimes, because it's a very difficult to choose and have the 3 different way of the experience for this disease. It's a real up to date. Shunji, every time you have a new vision, we hope that your vision now is for a regenerative cell reconstruction without patches. We learn from the school of Bologna that they don't like to add some that is not native tissue. So again, thanks a lot. We will keep in touch, and we will, thanks for what you did. Professor NIKAIDOH, you want to say something?
Yes, thank you very much for including me. Then I really enjoyed the Taormina, and I certainly would like to come back sometime. The theme of this afternoon, all of that discussion really pointed out how important it is to individualize our approach depending on anatomy and details and the need of the patient. That can be said by essentially everybody. And then I am so glad that is a purpose that we are here. We would use our best technique and ability to take care of all these complex patients. And thank you for including me.
Thank you very much. Grace, you want to say something?
Guys, it was amazing. Thank you very much. We really, really appreciate it. And I'm sure that people from all over the world learned a lot from you. It was a privilege for us from Congenital Heart Academy, and I'm sure everybody really enjoyed. Thank you, guys.
Thank you very much.
Okay, thank you, Grace and Sasha.